As I'm waiting for you guys to log on, can you guys hear me? Maggie, can they hear me? Great. And with this new Zoom technology, I'm remembering a terrific practical joke that a very geeky professor played on his class that I read about a couple of years ago. And what the professor did is, very geeky, nerdy guy, he contrived to make a mock-up of his email inbox that looked exactly like, like the kind of mail client we all have that lists the incoming mail. And then he made up fictitious, it said President Obama, Bill Gates, the very supermodels, so his inbox had and then he pretends to be fumbling as he connects the computer, and then, oh my goodness, and it's trying to hide it, the students are like, oh my God, Professor Smith is getting all this incredible email. Anyway, since I have to share my screen with you guys, I was worried that I have such a messy desktop screen, it would look ridiculous, but who cares? I can't, as usual, I can only see a couple of you, which is, I wish I could see you because I would love to ask you how the readings are going and things like that. So maybe today I'll pause at some point and we can see if we can get, in this admittedly very awkward fashion, some kind of conversation going. All right, so last time we talked about the social construction of illness and health, and we examined this idea primarily through the lens of female reproduction. And we saw how our ideas about what it is, what our ideas about what is and is not a disease, how that informs our response to disease, what actions we take as a result, and our further creation of knowledge, and indeed our perception of the world. This is a crucial idea. The social construction of medical phenomena affects what we do, affects how we perceive things. So it's not just idle theorizing. And we also began to be introduced to this notion of a natural birth movement that emerged in the 1980s and 1990s, and how, while quite understandable, the situation in fact is quite complicated in that the burden of mortality in natural circumstances is unacceptably high. And I briefly alluded to this, something which you don't need to necessarily know, but it's an interesting idea in philosophy, which is this idea of the naturalistic fallacy. Just because something is natural doesn't mean that it's good. Natural childbirth, women can die at 100 times the rate, let's say, of non-natural childbirth. So we need to think in a more subtle way about some of these topics. Today, we're going to be shifting gears and talking about the experience of death and dying, and it's going to be a rather more somber session today. Now, as many of you may remember, I'm a hospice doctor. When I was clinically active and I stopped seeing patients about 10 years ago, I used to take care of people who were dying. And I did this for, 15 years in my career. And I did this for about half that time. I practiced in the south side of Chicago, primarily impoverished African-American part of the city, taking care of people who were really very marginalized by almost by race, by economic status, by illness status. These people were suffering. And the other half of my clinical career, I practiced at Mass General Hospital and at Mount Auburn Hospital, which were Harvard-affiliated hospitals. And also earlier in my career at that time, I was actively involved in advocating for improving the care of the dying in our society. In some ways, I don't think I'll go into necessarily today. But the reason I mention this background is that I spent a lot of my life at that stage of my career being very concerned about the care of the dying. And it's fashionable to speak about vulnerable populations in our society. But it's hard to imagine a population that's more vulnerable among us than those who are dying. I mean, think about it. There are people around us in this society who, as a class, form a group of people who are terminally ill. They are not able to band together to advocate for their interests, right? The terminally ill aren't marching in the street. What do we want? Better end of life care. When do we want it? Now. That's not what they can do, okay? They are really vulnerable. They can't petition their representatives. Their time horizon is foreshortened. And I think this has something to do with why the care we give to the dying in our society is so lousy. Even family members of the dying, it's a transient state. Some of you in this class, no doubt, have had grandparents or parents die, or siblings perhaps. Awful experiences some of you have surely had. But it ends, it passes, and few of you are radicalized to effectively work to improve the care of the dying in our society. So this is something that has been very near and dear to me for a very long time. I'm not an activist anymore in advocating for improving care of the dying. I've moved on to other topics, but I spent like 10 or 12 years of my life really worried about how we care for the dying for a host of reasons. So let's begin by understanding the experience of death in the United States. The typical trajectory to death is that at some point there's an onset of illness. And 75% of Americans die after a chronic disease, after many years of illness and treatment. So it's usually not sudden. The people die of something they know. They see the thing that will kill them, and they experience the thing that they will kill them for a while. At some point in the course of caring for this condition, whatever it is, end-stage renal disease, cardiac failure, various kinds of solid tumors, cancers, or leukemias, which are not solid tumors, or whatever it is that they have this experience for quite some time, and then they enter the terminal phase of their illness, which lasts between 2 and 12 months. And in this terminal phase, they have a gradual decline. Now, the pattern of that decline, whether it's like a steady kind of monotonic, smooth decline, or a stuttering decline, or like a kind of a curvilinear decline, depends on the diagnosis. So different diseases do different things to you as you approach the end of your life, and they give you different symptoms. Most Americans have some kind of pain near the end of their life over that last 2 to 12 month period. But they also have other symptoms that many of you probably don't think of, including a symptom called dyspnea, which is shortness of breath. And about half the time, people have shortness of breath as they approach the end of their lives. And this can be very, very distressing to people, sometimes more even than pain. Or they can have fatigue, which is very common, or depression, which is very common, or more uncommon symptoms like itching. Some fraction of people who are dying get severe itching near the end of their lives. It can devastate them. It's very difficult to treat severe itching in terminally ill people near the end of life, trust me. And then at some point they get to the last week of their life. And this last week typically involves a kind of shutting down. This man that you see in this photograph is probably about a week, I would say, from the end of his life, maybe 2 weeks. And often there's a kind of disconnection that people begin to have. There's a kind of process of letting go. And if you think about that, if you just stop for a moment and think about what it's like to be dying, and the letting go that is involved, you're not just letting go of your life, which is hard enough. You're letting go of your family. You're letting go of any future aspirations you had. You're letting go of your bodily integrity or your dignity. Many people with different sorts of symptoms at the end of life are naked in their beds because their clothes, they itch or they hurt or they bother them. So it's this process of just letting go and letting go. It's almost a Buddhist process, actually, of evanescence, just disappearance, actually. And then your body functions begin to stop. And finally, your breathing, often in about half the patients, gets a very typical breathing pattern in the last couple of days. About half the time, people lapse into a coma. Once they lapse into a coma, they typically have about a week to live. And then their heart stops and they die. And many people, most people, I would say in my experience, manifest the kind of classic Kubler-Ross, Elizabeth Kubler-Ross kind of stages of coping with death, although not in the canonical order necessarily. And these include denial. So the far from death, people often deny that they are terminally ill. Anger, people are quite angry at being seriously ill. Bargaining with God, like spare me and I will do these good deeds. Depression, and finally, and typically, acceptance. Now, there's been a long, huge literature now ever since Kubler-Ross's famous work, and people don't necessarily go through all these stages or in the same sequence, and they can bounce around. But in my clinical experience, most of these, denial, anger, bargaining, depression, and acceptance, are things that most patients will manifest. And often there's hope in all stages. And as a clinician, as a doctor caring for the terminally ill, the ability to engage patients around hope near the end of life was a crucial skill as a doctor. And you might think, you 20-year-olds, probably none of whom are terminally ill, you might think, how can someone terminally ill have hope? And one of my teachers said to me when I was being taught how to care for the terminally ill, said to me, Nicholas, what makes you think terminally ill people don't have hope? Of course they have hope. And in fact, one of the things I would do when I was talking to terminally ill people, I would literally say to them, a risky question that's shocked some of you. I would say to them, tell me a little bit about your hopes and dreams. Which probably strikes you as a kind of, how could I ask terminally ill people such a question? But they would answer, because terminally ill people have hopes and dreams. Many of them, for example, might say, I just hope my wife is okay after I die. And it's very important as a doctor to actually engage such a question. And the dying have many concerns. They're concerned that the world is going on without them. It's very poignant. They're worried about their families. They have fears about what will happen to them after they die, or about nothingness. About 20% of them feel awfully alone. They often feel a kind of disembodiment or a disconnection from their bodies, or anger at their bodies, which I would also often ask about, or a kind of a sense of being in the grip of an inexorable disease. Think about that. Think about how all of you like to feel in control of your lives. Imagine what it must be like to be in the grip of a disease which will not let you go. Or they are engaged with a search for meaning, which is another very important thing to engage if you're a doctor caring for people who are seriously ill. But most worrisome to me is, as we shall see, that people in the United States who are dying have bad deaths with little attention to any of the things that I've just told you, despite being in the richest country on the planet and despite receiving medical care. Let's see if we can get a visual picture of what a dying person looks like, something that in modern life is usually far removed from most of your experience. If you were Yaleys 100 years ago, or 20-year-olds 100 years ago, you would have had more experience seeing people as they went through this phase. This is a woman a few years before she died. And here she is after the onset of her illness, but still more than a year before her death. And you can see that illness is very aging and exhausting. And look at her husband and his concern. You could just see it in their eyes. And here she is closer to death. And I'm showing you these pictures to try to give you a feel for what the experience of death in our midst might be like. There are people around the country right now. There are, hundreds of thousands of people that are going through this experience. And it's very hard sometimes for young students who are by and large young and healthy to get a feeling for the experience of the dying. But the dying themselves often have a rather different perspective. And a patient that was very dear to me, when I asked her what it was like to be dying, she said to me that she was ready to die, and she had this tremendous equanimity about death. And I couldn't understand it. I was a young doctor. And I asked her to tell me about it. And she said, what you can't understand is that a dying patient needs to die like a sleepy person needs to sleep. And you can't understand that because you're young and healthy, she said to me. But I, who have lived with my condition for 20 years, know what I'm telling you. And so it's not often that people have that type of equanimity near the end of life, but some do, many do. And it's very important as a doctor to listen to them. This is Frank. He's dying of lung cancer at home in rural Pennsylvania. I think he dies the next day after this photograph. He's shown here with his son, his son's wife, and his grandson. This is a very typical appearance of a person dying of of solid tumor, very emaciated, very exhausted. And what I want you to focus on, it's not so much the physical appearance that Frank has, which is typical, as I said, but rather I want you to focus on the way that Frank is embedded in his family, even while he is dying, and on the emotions in the faces of his family. People manage this just fine when there's good symptom control and good professional help and support. We can actually, as a society, take good care of people who are dying and their families if we make the effort. Here's a man with advanced pancreatic cancer and his wife and a very large dog. He died about 6 weeks after this. And notice the fun in the room, right? They're smiling and they're playing. And getting a feel for what a good death is and how often it is achieved in our society and what might be done to facilitate such an outcome is a key focus of today. And I had another picture here which somehow got deleted, which was of another case study that I wanted to describe for you. And I don't think I can find it fast enough to show you that story. Unfortunately. I wonder if I can, let me just see if I can find it because it's another poignant story. Let me just see here. I won't be able to find it in time. Anyway, you get the idea. It was a story of a middle-class African-American man with ALS and his wife. He was a gynecologist and he was dying. And it's an incredible photograph when you see this couple. You can see the love in their eyes, and you can see his the difficulty he has in letting his wife go. He's dying. Of course, she has difficulty too, and but his willingness to die. It's an incredible photograph. I don't know why it's deleted from this deck. Anyway. This shows that death is primarily a problem of the aged, though not exclusively so. So most people who die in our society are 65 and older, 75% of the time. 10% of the deaths are 55 to 64, 13% is 25 to 54, and your age bracket is thankfully one in which death is not common. And these data are old, but the story is the same. This shows how much money we spend on caring for people near the end of life. These are quite old now, but again, the gist is the same. We spent about $25,000 on the last year of life, and about $10,000 the previous year, and $7,000 a year before that. And the expenditures in the last year of life decline substantially with age at death. That is to say, the older you are, the less money we spend on you in the last year of life, but they do not vary by race and gender in multivariate models. So we don't spend much differently on blacks and whites and men and women, for example, near the end of life. And Americans clearly spend enough money that they're entitled to terrific terminal care and a good death. And 25% of all healthcare spending by Medicare and in general is spent on the last year of life. So of all the money we spend in our society on health, which is a huge, vast sum, 25% of it we are spending in the last year of life. So we're spending plenty. And what do Americans want for the money that they are spending? One survey of seriously ill patients from your reading found that numerous attributes of a good death, there were numerous attributes, but today I'm going to discuss how we are doing in meeting 5 key attributes about which there is generally unanimous opinion. And these are being free of pain, so 93% of Americans felt that it was very important, not being a burden to family, having someone who listens, dying at home, 35% in the survey I sent to you, but more than 70% in other somewhat better surveys, and knowing what to expect, 96%. Those are the 5 key attributes of a good death, although there are many others which are also listed on this slide. And knowing what to expect involves having a prognosis. And I will note that having family present, where is that? Right here. 81% of Americans felt that having family present was important to a good death, but this has been an enormous problem during the COVID-19 pandemic, as you may have been reading. Countless Americans dying alone, as we will see, and which is also typically a feature of plague, as we'll see when we get to the COVID lectures next week. Yes, David, you had a question.
Sorry, I was just wondering if you could repeat that statistic about the 25%. Did you say that 25% of like all medical, like in the
all
last
money
year
we spend is spent in the last year of life? Yes.
So like in my, like on average in my life, 25% of the medical, but like I know it's an average.
No, not across your life. I meant of the money spent in the United States today on all medical care for every American, 25% of that money is money spent on people who are in the last year of life.
Cool, thank you.
So we spend, of all the money we're spending to take care of illness in our society, a huge fraction, unsurprisingly, is going to the end of the people's lives. But the point is that's a large sum of money. So how are we doing for the sum that we are spending? Other questions? So some of the best data we have about the dying experience in the United States comes from a very old study now known as the support study, which is older than 20 years. And this was a large cohort study that was embedded within a randomized controlled trial that actually tried to make things better. And support stands for Study to Understand Prognoses and Preferences for Outcomes and Risks of Treatment. It involved nearly 10,000 patients, 9,105 patients, with 9 life-threatening conditions that were studied between 89 and 94 in 5 hospitals in 5 different states. And the study itself cost over $30 million to do. And the conditions were a range of deadly things like acute respiratory failure, severe congestive heart failure, severe cirrhosis, metastatic lung cancer, metastatic colon cancer, multiple organ system failure with sepsis, and so on. Deadly things. They try to say, well, how are Americans doing at the end of life, and can we make it better? And the beginning part of the study tried to just describe how are we doing. And what it found was that 50% of Americans experience moderate or severe pain at least half of the time within the last few days of life. Indeed, various studies, depending on setting and definitions, yield estimates that between 40 and 70% of the time, Americans have significant pain when they die. And this number has not changed in decades, as your reading, the Singer 2015 reading shows. So just think about that. Something like half of Americans die in pain. I mean, that's like a really bad statistic, guys. That's just really bad about our society. And 50% have prolonged suffering of some kind, more than a week in ICU, in coma, or on a ventilator. And 90 to 95% of patients want others, including their doctor, to listen to them near the end of their lives, for example, about the nature of the care they're about to receive. But the support study found that 53% of the time, the physician did not understand that a patient wanted to avoid CPR. In other words, even though most Americans want their doctors to know what they want, half the time the doctors have no clue about what the patients really want when it comes to their end of life care. For instance, with respect to CPR. And 70% of the time, the physicians did not discuss CPR with seriously ill hospitalized patients, which is really bad. Like, doctors, even if it's difficult and unpleasant, should be engaging patients in a conversation. What would you like us to do if your heart were to stop? Should we allow you to die, or should we make an effort to resuscitate you? And of course, when I talk to patients about this topic, I don't say it quite that way, but that's how I'm summarizing it for you to understand what the conversation is supposed to be about. And 46% of the time, physicians did not discuss DNR orders with these seriously ill hospitalized patients until 2 days before death, which really reflects crappy communication with such patients. You should not be waiting till the patient is 2 days from death to have these conversations. So given these and other failings in the care given to seriously ill patients, and given the lack of adequate attention to issues of palliative care, the support investigators designed an intervention whose objective was to improve 5 targeted outcomes. They wanted to increase patient-physician agreement on CPR preferences. That is to say, they wanted to make sure the doctors and the patients had the same idea about what the patient wanted. They wanted to enhance the incidence and timing of DNR orders. They wanted to reduce the days in ICU, in a coma, or on a ventilator before death. They wanted to enhance pain control, and they wanted to improve hospital resource use. So they designed a specific intervention that was supposed to improve these 5 outcomes. And the intervention had 3 important elements. First, it involved developing a reliable model-based system for generating prognoses and allowing for the timely communication of these to the responsible physicians. In other words, they said, we're going to get a computer model that's going to predict what's likely to happen to these patients. We're going to give that information to the doctors rapidly, so the doctors kind of know what to expect better than they did before. The intervention involved the elicitation of patient and family preferences for end-of-life care and the timely communication of same to the responsible physicians. So they made a provision for a special nurse whose job it would be to talk to patients and families about what the patients wanted to be done at the end of life. And the nurse would then relay this information to the doctor. And it provided for the provision of a skilled nurse to facilitate all these interventions and discussions. And they delivered this intervention to half of 4,800 patients in the latter half of the study. So the study had about 9,000 people. Half of those were in the roll-in period, where they quantified what was happening. How was America doing in terms of caring for people at the end of life? Then they began the RCT part with the remaining 4,800 patients, and half of those were randomized to get this intervention, and half were randomized to be in the control group to get nothing. Okay, this was the design of the study. And unfortunately, the intervention did not work. For example, here are the results regarding the effect of the intervention on pain. Please focus on the right-hand panel. This shows that there was no change in pain after the support intervention, which was measured during the 2nd week of hospitalization. On the x-axis is the year of the study. On the y-axis is the percent of the patients with moderate to severe pain, and whether you were in the intervention group in yellow or in the control group in dotted orange lines, the pain levels were the same across time. And these results show the temporal trends in the run-up and afterwards. This was the interval of time in which they paused to develop the intervention. So they track what was happening in patients here, then they paused to do the intervention, they implemented the intervention, and there's really no difference. Here, about 20% of the patients had pain throughout the study, the same as in the intervention group. And incidentally, this number is different from the percentage of 50% that I mentioned a couple slides ago, because the time period under consideration here is different. This is being in chronic pain versus just the last 3 days of life. And in fact, this is in all patients, not just those who are dying. But the point is that there was no movement in pain despite this intensive effort. In fact, the intervention did not improve any of the targeted outcomes. It did not improve communication between physicians and patients and families, didn't improve understanding that the patient wanted to avoid CPR, had no effect on the timing of DNR orders, didn't reduce days in ICU, in a coma, or in a ventilator, did not affect pain control, as I just showed you, and had no impact on hospital resource use. So these people spend 5 years, $30 million. It was a huge effort to try to improve, to quantify the pathetic care of the dying in our society and to try to improve it, and they had no effect on any of the outcomes that they tried to affect. And this was a very dispiriting conclusion. Like when I was a young doctor, when this study came out, people were gnashing their teeth about it, because there are many doctors, myself included, who are very committed to improving end-of-life care and who thought that this could help, and yet it did not. And it showed that it's going to be really hard to improve the care of the dying in our society. And after the intervention failed, a number of commentators began to speculate about why. And here's some thoughts about what went wrong and about what other changes we might need to make in order to improve care of the dying. It turns out that the physician did not actually get the prognostic information 41% of the time. So despite the fact that we had a model that generated the information, a statistical model, and a nurse whose job it was to provide it, maybe as much as half the time, the doctor didn't get it for one reason or another because of the way hospitals work. Conversations between doctors and patients were not actually increased or improved. So even though the doctor was given prognostic and preference information, the doctor didn't act on that. The doctors didn't want or have the time to actually talk to patients about what was going on. The patients may also have played a role in having persistent misunderstanding of their situation. It's not just the doctors. Remember, both the doctor and the patient, their knowledge needs to be affected. And the physicians might actually ignore patient preferences. 50% of the patients wanting to be made DNR were not made DNR. Now, the support study is not our only source of information about care of the seriously ill, of course, and there's quite a bit of research on this, and I gave you one much more recent reading that describes what's happening with the care of the dying in our society. And actually, the situation with respect to end-of-life care, and specifically with respect to pain relief, is so much worse in the rest of the world. This slide shows per capita consumption of morphine in 158 countries around the world. So here's Austria. So on the x-axis are the countries arrayed, and on the y-axis is milligrams of morphine consumption per capita. Austria was the highest, and Canada. Here's the United States, third from the top. Here's Ireland. Here's poor Greece. And the global mean is 6.28 milligrams per capita. Here's Pakistan and Honduras, where my laboratory works, and Angola. The point is, in most of the world, if you're dying, you die in agony. We don't even give you morphine, which is cheap. It's pathetically cheap drug and effective and been around for centuries. Doctors have known how to use opioids, and yet we do not provide it. So as badly as we're doing in our country, this slide just gives you an illustration of how much worse it is. In sub-Saharan Africa, 1 billion people on that continent, death is just appalling. I used to be involved with a hospice, a man who was trying to improve hospice care in sub-Saharan Africa. He spent 20 years of that of his life. Very difficult to improve. Well, that's pain. Next, let's look at where people die. What determines where the place of death? Does it have something to do with what patients want? Well, most people, as we saw, say that they would prefer to die at home, but unfortunately, very few people are able to realize this preference, and home death is uncommon. This slide shows site of death in the United States in 3 sentinel years, 89, 97, and 2007. And if you look at, these are decedents 65 and older. And if you look across time, home deaths have risen in the, whatever it is, nearly 20-year interval from 15% to 24%, but hospital and nursing home deaths are still exceptionally high. So most Americans want to die at home, but elderly Americans, only 24% of them are able to die at home as of 2007 in this ongoing cohort surveillance study, longitudinal cohorts rather. Or what I mean is serial cross sections in that data. In the support study, in fact, there was no relationship at all between a patient's preference for dying at home and whether they were able to do so. So this slide shows the percent of support deaths occurring in hospital according to the preference for the patient for dying at home. So on the x-axis is the patient preference for dying at home. Do they really want to die at home? Very much. Quite a bit want to die at home, moderately, a little bit, or not at all. And on the y-axis is the percent of patients dying in a hospital. And roughly speaking, if you could look at this slide, it didn't seem to make a lot of difference. Yes, there's some effect, but only 57% of the people who very much wanted to die at home instead died in a hospital, and so on. If you look at the slide, the point is that this line is roughly horizontal, and that whether you die in a hospital or at home is to a significant extent independent of what the patient's preferences are. However, one thing that did help a patient die at home was the availability of hospice care. Now, what is hospice care? Hospice is a mode of terminal care. It's not a place you go, at least in our society, it's not a place you go. It's a philosophy of care. It's a mode of care, of terminal care, that emphasizes palliation and relief of a patient's physical, emotional, and spiritual pain and suffering, rather than treatment of the patient's underlying disease. Hospice care neither hastens nor delays death. It is the active, total care of patients whose disease is not responsive to curative treatments. The goal of such palliative care is the achievement of the best quality of life for patients and their families. Now, in the United States, hospice care is multidisciplinary and outpatient. Most people who get hospice care in our country, the great majority, get that care at home or in a nursing home sometimes, and occasionally in a freestanding hospice building, but usually it's at home. And it has numerous documented advantages. It's home-based. It provides for the superior management of pain and other non-pain symptoms, and it's associated with higher patient satisfaction. And over 30% of elderly decedents use hospice at the time of their deaths, and this number rises for cancer patients. About 65% of American patients dying of cancer, of elderly cancer patients, will get hospice care. And indeed, two predictors of whether a patient died at home were structural factors unrelated to individual agency, unrelated to individual preferences, such as hospice spending. Each additional $10 that Medicare spends per beneficiary yielded a 2.8% decrease in hospital death. So the more money that Medicare was spending on hospice care in your area, the less likely you were to die in a hospital. And the regional bed supply. Each additional bed per 1,000 Medicare beneficiaries, Medicare is our insurance system that cares for the elderly, yields a 5% increase in hospital deaths. So the more hospital beds that are in the neighborhood where you are when you're dying, it's like a giant sucking sound, just pulls you into the hospital. And the more we spend on hospice care, the more you're likely to be able to at home. So these policy levers that are structural factors, the structure rather than the agency, plays a big role in what happens. This slide shows geographic, so-called small area variation in the United States. We'll return to this topic of neighborhood variation in 10 lectures or something. But here the United States is divided into 306 hospital referral regions. And it shows the percentage of deaths dying in a hospital, the percentage of patients dying in a hospital in each of these 306 regions. And if you look across the country, the dark blue are 40% or more die in a hospital, to the light blue, less than 20%. So there's a lot of variation from place to place in the fraction of patients who die in a hospital. And the reason this is important is that it says that where you live affects the kind of healthcare you get, possibly even more important than your biology. Thus, if you're a patient who wants to die at home, and if you happen to live in an area with lots of hospital beds, you're especially unlikely to have your wishes fulfilled. But on the bright side, what these results suggest is that public policy matters and can affect what happens, both in the sense of increasing the likelihood of a particular outcome, and also in the sense of increasing the ability of people to realize their own objectives. So we can pull policy levers to affect how many people do we want to die at home or not, and we can pull policy levers to affect are patients better able to realize their own agency. That is to say, they may want to die in a hospital, they may want to die at home. What systems do we put in place to allow them to have what they want? And as I said, this is yet another example of the classic issue of structure versus agency. Well, let's turn now to yet another aspect of a good death that I mentioned at the beginning. While 89% of patients rate not burdening their family members as a key aspect of good terminal care, the majority of Americans, have deaths that are actually quite burdensome. So if you look at the family impact of illness in the original support study, 34% of Americans needed large amounts of family caregiving. 20% had major life change for a family member, like, they quit their job, for example, to care for someone who was seriously ill. Other family members had stress. 31% of American families lose all or most of their life savings in caring for someone who is dying. A great source of bankruptcy in our society is simply that people get sick. 29% lose a major source of income, 17% have a major change in family plans. The bottom line is 55% of Americans have at least one of the above serious, burdensome impact. So it's burdensome on families, despite the amount of money that we are spending. Finally, let's look at the fifth element that I introduced, which is prognosis. Here's what one patient had to say. I can no longer remember if this is one of my patients or another doctor's patients. It's been so many years since I did this work on prognosis. Oh, this was one of my patients. I remember this patient. It's actually the daughter of a patient. And she said, "How long will it be, doctor? I can deal with the physical part of caring for my dad dying of renal failure, but I just want to know. I watch him breathe, and with every breath, I wonder if that will be his last. The nurse said, we can't say how long it will be, but I want to know because it hurts me to see him like this, and I don't want to see him like this. Is he going to linger or get worse? What is going to happen? And I want to be with him as much as possible, and I want to be there when he dies. I don't want to miss that." This woman has every reasonable expectation that the medical care system would provide her with knowledge needed to better manage not only her father's suffering, but her own. And the question is our healthcare system organized to provide this kind of prognostic information? Larger, more formal, quantitative studies support the salience of prognosis in patients' minds. Again and again, surveys of patients document that they rate prognosis as the #1 piece of information they want from their physicians. The patients know what their diagnosis is. Remember, I told you most people, 75%, die after a chronic illness. It's not a surprise what's going to kill them. If you have lung cancer, you know what you're going to die of. Furthermore, they're often not so interested in treatment. Yes, they want to be treated, but the details of their treatment are not as important to them as the impact of their treatment on their prognosis. So the question is, are doctors able to formulate and communicate a reliable prognosis, one that both patients and doctors could then use and act on? My laboratory conducted a prospective cohort study of prognostic error. This was a study I did years ago, and I think it was in your readings. And our objective was to quantify the magnitude and nature of error and evaluate some of its determinants. What are some patient factors and some physician factors that can help us understand when are doctors better able and when are they less able to make predictions? And this is a slide of some of our most basic results. On the x-axis is the observed survival. This is for 468 terminally ill patients. It shows the formulated versus actual survival. So on the x-axis is the observed survival. How long did the patient actually live? And on the y-axis is the predicted survival, what the doctors told us when we asked them, how long do you think this patient will live? And if the doctor made a prediction that the patient would live 90 days and the patient did live 90 days, you'd get this dot right there. So this diagonal line shows the line of perfect prediction. Now, of course, we don't expect doctors to be absolutely perfect, but let's define a zone of accuracy where if the doctor predicts plus or minus 50%, then we'll call that an accurate prediction. Well, only 20% of doctors, were within plus or minus 50%. And then if you look at the points, you can see that most of the points are above the line than below the line. 63% of the points are above the zone of accurate prediction. Doctors are over optimistic in the predictions that they make about people near the end of life. So these are all patients that the doctor thought would live 365 days. The doctor thought the patient was going to live a year, and the patients all died within a month. That is a gross error. And actually, it's a bad error because it adversely affects patient experience. And some consequences of such error are that patients are offered painful treatments. Hospice nurses have a joke that's famous among hospice doctors. Hospice nurses ask, what is the function of nails in a coffin? To keep the oncologist from administering more chemotherapy. So the idea is that if you're over optimistic about how long a patient's going to live, you might recommend all these painful treatments, which are futile and imposing all these risks on patients and suffering on them for no benefit. If you also were over optimistic, this might explain why doctors fail to get DNR orders, because they don't think the patient's dying. They're unaware that the patient's dying, so therefore they don't get the DNR order, which is crucial to having the patient have a good death. Or it might explain, and it does explain, why doctors refer patients for hospice care so late in the course of illness. Well, what about the communication of prognoses? Do physicians discuss prognosis with patients and families? And if so, in what way? In my lab, we also looked at the communication of prognosis in that study I just told you about, and we examined physicians' intended prognostic disclosure in 326 terminally ill cancer patients who had been referred by their own physicians for hospice care. So this is a population of patients with cancer who are under the care of their own doctors, who were then sent for hospice care. So the doctor knows the patient is at the end of life, and we asked the doctor, okay, and the doctor had just told us a prognosis. So the doctor was willing and able to communicate to us a prognosis. And we said, what would you tell the patient? 96% of the time, for 96% of patients, the physicians were willing and able to formulate an objective prognosis and tell us. And when we said, what would you tell the patient? 37% of the time, they said, I would tell the patient the same thing I told you. 23% of the time, they said, I would not tell the patient a thing. And 40% of the time, they practice what we call discrepant disclosure, which is that they tell the patient something different than what they told us. 70% of those times, it's over-optimistic. They told us, I think the patient's only going to live a week. What'd you tell the patient? I told him he was going to live a month. And 30% of the time, it was the discrepant disclosure was pessimistic, where they told the patient something harsher than what they told us. And this graph combines the results from both of our studies. It illustrates the difference between actual survival, objective or foreseen survival, and subjective or foretold survival for 300 terminally ill cancer patients. It's the difference between the formulated and communicated prognosis. So here is the fraction of patients surviving. It's a survival curve. Here is time. Here's the actual survival. And so the median survival is 24 days down here. And the median predicted survival is 75 days. So the patients on median survival is 24 days. Median predicted survival, what they told us, was 75 days. And median communicated survival was 90 days. So patients become twice removed from the reality of their condition. First, because of unknowing, unconscious errors in the prognoses that doctors formulate. And second, because of knowing conscious errors in the prognoses that doctors communicate. And this kind of inaccurate and overly optimistic survival can harm patients. It harms them because, as I said, they take risks and make decisions that are unrealistic about treatment and about their lives. So here again are the 5 items that the great majority of patients think of as key parts of having a good death. So being free of pain. Can you see my red pointer? Maggie, can you see the pointer? Yeah. So this is the percent of patients agreeing, very important. This is from one of the first slides that I showed you early on. 93%, 89%, 95, 70, and 96%. What fraction of Americans have we seen now are able to achieve these objectives? And you can see how pathetically we are doing. We are not able to satisfy these expectations. And these problems persist despite the fact that we spend roughly $100 billion every year caring for patients in the last year of life, and despite the fact that everyone eventually experiences this outcome. Unlike other kinds of healthcare challenges where we say, well, why are we spending money on this? We say, well, only a small fraction of people have this problem. We all die. We're all going to have this problem. So, and we spend a lot of money on it, and yet we don't fix the problem. So we can conclude that the quality of death in America is poor, that this poor quality varies in discernible ways, and that improving the care of the dying is not going to be easy. Now I'm just looking here. Are there any questions at this moment, or maybe 1 or 2 questions I could take? Does anyone have any questions? I'm going to pause at the end for more questions, but if someone has something they want to ask. Maggie, can you handle the questions? I can't really see who's.
Miriam. Thank you. Yeah, the question I have is sort of about why doctors have more optimistic prognostics, and like why doctors may refuse to respect DNR. Like I know that from some doctors I know it's very emotionally taxing for them when a patient of theirs dies, especially if they're in sort of a field where the expectation is that they like save their patients. So how do you think that problem can be mediated, sort of the emotional side coming from the doctors and it being hard for them when they lose a patient?
Yeah, so the DNR thing I'll come back to in just a few slides. I can talk a little bit about that. The prognosis thing, I wrote a whole book about this called Death Foretold, Prophecy and Prognosis in Medical Care, which examines some of the reasons that doctors do and don't make predictions. But very briefly, there are a number of reasons. One has to do with doctors' quasi-magical and religious beliefs, believe it or not. For example, doctors believe in self-fulfilling prophecy. So this makes them want to avoid negative predictions and favor positive predictions, right? They're kind of an optimistic bias. Doctors also, often if you ask them, why don't you make predictions? They'll often say, I don't make predictions because that's a godlike function, right? God determines what happens, not I. For me to make such a prediction, it would be almost unholy in a way. So those are a couple of the reasons for optimistic bias. I should say there are other circumstances in which doctors have pessimistic bias, and it's discussed at length in Death Foretold. But those are a couple of reasons. The emotional, the objective difficulty in the task clinically, it's hard to make accurate prognoses, the emotional burden that you mentioned, and a set of quasi-magical and religious beliefs that doctors have. All of those militate against prognostication.
Alex.
Do other countries similar to the US also spend such high percentages of on healthcare spending in the final year of life? And how does that affect outcomes there too?
I don't know the answer to that offhand. I don't know what spending at the last year of life is in other countries. I have been to England, and I can tell you the end of life care in England strikes me as superior. Just subjectively. I can't recall offhand formal studies, for example, of what fraction of Brits die in pain compared to Americans. But I've been to St. Christopher's Hospice. I've taken care of people in hospices in England, in several cities, and I think they do at least they used to do a better job than we did. Let's go on, and I'll come back to some more questions at the end. So end of life care is often so bad in our society that people have advocated for and hospitals have implemented death with dignity programs in several states, which allow doctors to prescribe lethal doses of barbiturates for self-administration by patients who meet certain stringent criteria. And this slide shows various attributes of patients participating in one death with dignity program at the Hutchinson Cancer Center in Seattle, compared to groups from Washington State and Oregon more generally, and this was taken from your readings. And unsurprisingly, these patients have the same primary concerns about their end-of-life experiences as anyone else. So, why would the patients, are they worried about loss of autonomy, loss of dignity, burdening their family, and what fraction of the patients, were enrolled in these programs? And they found that of the people in the Seattle Cancer Care Alliance Death with Dignity program, 22% were worried about burdening family. And in the Washington State and Oregon programs, the comparison groups, these were the percentages, let's say. And some of these percentages are lower, for example, burdening one's family, because this study assessed whether people felt they were a burden, not whether they feared that they might become one, okay? So these people, 22% felt that they were a burden compared to 38% and 36%. And 11 of 40 patients who participated, actually in this study, I just wanted to mention the median survival, no, not the median survival, this is the median, no, it's not on the slide. So not on the slide, but I'm telling you that 11 of the 40 patients who participated in this Death with Dignity program actually wound up living longer than 6 months, which also reflects the difficulties of prognostication. And 60% of the patients that got the lethal prescription actually used it in order to end their own lives. All right. So the question is, why am I discussing this, or why am I, why did I give you this reading? And And the reason is that, from my perspective, if we're doing such a crappy job caring for people at the end of life that they're actually asking for barbiturates so as to be able to end their own lives, we have a problem, right? The problem with these death with dignity programs, which on philosophical grounds I support, in other words, I am morally committed to the idea that any adult who wishes can end their own life. But I would ask a question, why would they want to end their own life? The problem with these death with dignity programs is they eradicate the pain by eradicating the patient. I mean, why wouldn't we do a better job providing better end of life care so we wouldn't have patients in such desperate straits? So what could be done to improve the sorry state of end of life care in our society? Well, I think we could focus on a number of things, including, enhancing communication between patients and doctors. I think there's still effort or things we could do to improve a doctor-patient communication in terms of activating patients or briefing them. In other words, you're a patient with cancer, you're going to go talk to your oncologist. Here's some tips on how you can talk to the oncologist to get better information. We can further investigate the optimal nature and timing of transitions between care systems. One of the leading determinants in crappy end-of-life care is the fact that patients are constantly switching where they're getting their care, from hospital to nursing home to hospice or whatever. We can evaluate the role of the specialty of palliative care, and we can develop the science of prognostication. We can help doctors to be better able to formulate and communicate prognoses. And we can design systems of care that address patient preferences. For example, by enhancing hospice care, or doing something which is now widespread, but when I first started teaching about this 20 years ago was not so widespread, which was adding pain as a fifth vital sign. So as many of you know, when you're in the hospital, the vital signs are temperature, heart rate, respiratory rate, and blood pressure. Those are the four vital signs, and a nurse will come in every so often and measure these things and put them on a clipboard at the foot of your bed. Well, there was a big move afoot, which was successful, which was to have the nurse ask patients to rate their pain. How much pain are you in? And the patient would give a rating and the nurse would record it. Now imagine being a doctor going into that patient and you pick up the clipboard and you're noticing the temperature. You're like, oh my goodness, the temperature is spiked. The patient has a fever. Better do something about that. Why does the patient have a fever? Or their heart rate is spiked. What's going on with that? We better think about that. Well, but if the pain is spiked, you can't say, oh, patient had a pain rating of 2 for the first week of hospitalization. Now it's an 8. Oh, never mind. I'm not going to talk to the patient about this. So quantifying and writing it down changed practice. So now pain as a fifth vital sign is very common in many hospitals. And listening to patients is the key to any redesign of our system for providing care at the end of life, in my opinion. Well, what might be done about this rampant prognostic error? There are several possible ways we could enhance prognostic accuracy of physicians and so perhaps optimize the choices they make with respect to the care they give to patients at the end of life. These are 4 techniques for enhancing prognostic accuracy. We could elicit prognosis from a dispassionate physician. So asking a doctor whose patient it is not, someone who doesn't know the patient, to make a prediction. If you're not the doctor caring for the patient, you don't have an emotional connection to the patient, your prognoses are more accurate. You could elicit the prognosis in terms of probability rather than time. Turns out if you change how you elicit the prognosis from the doctor, they can perform better. So if you ask the doctor, how long will this patient live? That's harder than saying to them, what's the probability this patient will live more than 30 days? They're better able to make a prediction. You can supplement the physician's estimate with machine learning models. This is a huge area in the last 10 years of research using artificial intelligence or machine learning methods to enhance the prognostic accuracy. And you can average the prognostic estimate across physicians. Which is you get multiple doctors to make a prediction and you average that prediction. Let's talk a bit just about the last idea. Suppose you get a doctor to make a prediction. Turns out it's more accurate if you get several doctors to do so, and then you average those predictions. And this has something to do with what's called signal to noise ratio. So let me illustrate this with a digression. Suppose we want to extract the changes induced in cerebral activity by a visual stimulus. We put your head in a vise and we flash bright lights into your eyes, and then we have an EEG that detects electroencephalogram that detects electrical signals in your occipital cortex, because as you may remember from your anatomy, the light comes in your retinas, it goes back through the optic nerve and and through the optic chiasm, and it travels all the way back to the occipital cortex. So now we're detecting what's your brain doing when we flash a bright light in your eye. So we need a procedure to separate the changes that are related to the stimulus compared to all the other background noise that's happening when your brain is flashing. And so this next figure, so here we are, we give you the stimulus, and this is the trace of the EEG from your occipital cortex. And the next figure is a simulation of this process. If we give to our subject a lot of stimuli, the basal activity is more or less random, but the changes induced by the stimuli are consistent across sweeps. So now, here is we give a stimulus and we get this trace, we give a stimulus and we give this trace, we give a stimulus, we get this trace, and so on. And now if we average across the sweeps, we can extract this signal. Because the noise is random. The noise, sometimes at a given moment, it's going up, sometimes down. When you average, it cancels out. But the stimulus is not random. It's buried underneath the signal. So this is what happens when you average. Now we see, aha, this is what's happening in the occipital cortex when we provide this stimulus. And this is the same thing that can happen if we take the prognosis from multiple doctors. If you get multiple doctors to prognosticate and you average their prediction, you now get a more accurate signal, and you remove the noise. Now, there are two final topics I want to discuss today before we have some questions and I let you go. One is this issue which came up earlier with one of your questions, which is who should speak for patients at the end of life? And many or most patients often cannot decide for themselves what should happen at the end of life. For example, because they're unconscious. We can't ask an unconscious patient, do you want to be DNR? So the question in that situation becomes, who should decide? Should the doctor decide? Should the family decide? Or should the patient at some earlier point in their life decide? And as we saw, 50% of patients are in no shape at the end of life to make their wishes be known. And we saw also that 53% of patients had physicians who were unaware of their preferences. So we can't rely on the doctors either. How are we going to treat patients the way they would want to be treated at the end of their life? Well, substituted judgment has been proposed as a method for promoting autonomy of mentally incapacitated patients. But the accuracy of surrogate decision makers in reflecting the true wishes of patients may actually be questionable. In this study, 70 currently competent but chronically ill elderly patients were paired with close family members and with their primary care providers, and the wishes of patients were compared to these possible surrogates. The patients were queried regarding a hypothetical CPR scenario under circumstances of current health and progressive dementia. And most patient respondents chose to be resuscitated in both scenarios. And most patients predicted that both their physicians, 90% of the time, and their family members, 87% of the time, would accurately represent their wishes. So most patients wished to be resuscitated, and the great majority of patients thought their doctors and their family members knew what they wanted. But in fact, neither type of surrogate was able to do so. The percent agreement ranged from 59 to 88%. So here we're looking at substituted judgment. We're looking at the primary care doctors. Do primary care doctors know what patients want in this sample, in the current health scenario, or in the dementia scenario? So here's the patient wants to be DNR or get CPR, and here's what the doctor thinks. So the diagonal elements are when the doctor and the patient have the same opinion. I'm sorry. This diagonal is when the doctor and the patients have the same opinion. 47 patients want to get CPR, 47 doctors think they do. But the off diagonal elements are when there's a discordant opinion. And there's a lot of discordance, not only in the current health scenario, but even more in the dementia scenario. And in fact, Physicians do no better than chance alone. And physicians tended to want to withhold care more. That is to say, the above diagonal element, the doctor wants DNR and the patient wants CPR. This number 14 is higher than this number 5. So when doctors didn't just err at random, they were more likely to think the patients did not want CPR, whereas the patients did. And family surrogates did somewhat better, but were still far from perfect, especially in the forecasted state of serious illness. So similar results for family members, especially in the dementia scenario. And it turned out that few patients had ever discussed their preferences with their family members, 16%, or their doctors, 7%. So this state of affairs is especially bad. And one of the reasons it's bad is that actually nobody's talking to each other. So increased communication may offer some opportunities for improvement. Well, if doctors and family members are lousy proxies, what about patients themselves? Alas, it is possible that our own preferences are not stable or consistent, and that the test-retest reliability of patient preferences is no better than in the patient proxy pairs. But there's more. In other words, if I ask you now, what would you like done to you in the future? And then I come back and I ask you in the future, you may not be a good predictor of what you'll want in the future. And there's a more general theoretical problem here, which is the question of what is the relationship between your present self and your future self? Is your present self an accurate forecaster of your future self? And part of the problem is that different people in different states assign different utilities. A person with 2 arms may think it is a worse handicap to have just 1 arm than a person with 1 arm. Many years ago, when I was a young doctor in training, I went to a conference where one of my colleagues had 1 arm. I don't know if he lost it in an accident or he was born with 1 arm. I think he was born, now that I remember. And we were at a bar one night after the conference, and we were all talking about how much we would be willing to pay not to live with 1 arm. And the rest of us with 2 arms were offering huge amounts of money. And then we asked this guy, well, what would you be willing to pay to have this second arm given to you? And he said, $20. And we were like, we could not believe that he was willing to pay so little to have a second arm. But, he had lived his whole life with 1 arm, and he didn't think a second arm was necessarily that valuable. So people in different states ascribe different utilities to them. Now, this idea about binding your future self is sometimes known as an Odysseus contract, and it's the modern end-of-life equivalent of this is an advanced directive, right? Odysseus, as many of you remember in the myth, told his sailors to bind him to the mast, and when he heard the song of the sirens, no matter how much he demanded that they untie him, they were to ignore him. Do not do what I tell you in the future. Do what I tell you now. My present self is binding my future self. I am the true proxy for my future self. So ignore what I tell you in the future. Now, in fact, it turns out that people do not appear to estimate how they would find possible states they might find themselves in the future very reliably. For example, a colostomy is a situation in which there's something wrong with your rectum. Let's say we remove your rectum because you have cancer, and we bring a loop of bowel out to the surface of your body, and we connect it to a hole in the surface of your skin, and then we have a plastic bag there. This is known as an anastomosis, and you basically poop into the bag, and you have to clean the colostomy bag once or twice a day, remove it from your body, dump the poop out, stick another bag on, and so on. And if I ask you guys how bad would that be, you would assign that utility using the measures I introduced a few lectures ago with the time trade-off or standard gamble at about 0.8. But patients give it a 0.92. Patients don't think it's so bad to have a colostomy, patients who have one. The rest of us think it's much worse. We would give up years of life in order to avoid a colostomy. Or if you look at dialysis, being on dialysis, as this patient is, non-patients give it a 0.39. If you ask people, you describe for them what it is to be on end-stage renal disease, the consequences of it, and getting dialysis 3 times a week, they're willing to give up a lot of years of healthy life. Using the calculations I showed you a few lectures ago, but dialysis patients have a different opinion. Now, there are many possible explanations for these discrepancies explored by Peter Ubel and other psychologists and doctors. One possibility is measurement problems. In other words, we give an incomplete description of the future state. So when we tell you about the colostomy, we're really focused on the colostomy. And so we say all these things about, oh, there's poop in this bag and you have to change it and you can't defecate normally and blah, blah, blah. But we don't tell you about all the parts of your life that are normal. You can have sex, you can eat, you can be employed. So we just focus you on this very narrow thing, whereas the patient with a colostomy has a more total understanding of their disease. That's a measurement problem. Or we can have a lack of respondent integration across time. So in other words, the respondent doesn't think about the whole unfolding of their life. Or there can be something known as a focusing illusion, where you focus on one small part of the experience. Or there can be something known as a response shift, which is that a 10 to an 80-year-old is different than a 10 to a 20-year-old. This is the problem of, when we ask people to rate something, they're not in that state. They have a different way of thinking about it. Or most interestingly, the reason for these differences in these numbers could be this phenomenon of adaptation. People get used to things. And so my favorite example of this is this morning, when you guys put on your socks, raise your hands if you felt your socks going on your feet. I can't see your feet, but many of you may not be wearing socks. You felt your socks going on. And until I mentioned your socks, were you aware of your socks? No. That's because our nervous system is wired to detect changes in our environment. When you put your socks on, you feel them going on, and then the rest of the day, you're not aware of your socks. There's no reason for your body to inform you, socks are still on, socks are still on, socks are still on, inundating your brain with updated information on your sock status. Well, that's the same as you get with this. We adapt to these sorts of stressors. And so there could be changing utilities because of adaptation. And in fact, for adaptation to contribute to the discrepancy, two things have to occur. First of all, the patients have to adapt. And second, non-patients have to underestimate their probability of adaptation, either because they do not consider it or because they just don't believe that they could possibly adapt to having a colostomy, for example. And there are two kinds of adaptations: physical adaptation, you get used to the pain or whatever, and emotional adaptation. And strong emotions tend not to persist in people, and often there's a reduction in expectations. So if I ask you to think about having a leg removed, you might, oh my goodness, I won't be able to ski and go on hikes anymore. But now you might say, I no longer care about walking in the woods. It's okay. I don't mind missing a leg. Or people with arthritis can stop playing the piano and start singing, for example. So healthy people do not anticipate this adaptation, and this can explain at least part of the discrepancy. Moreover, patients themselves do not seem to appreciate the extent to which they have adapted. Still, one could debate whether adaptation ought to influence these utility measurements that we've made. Suppose, for example, that people are on a hedonic treadmill. Suppose that whatever happens to, this is the notion that you're on a treadmill, you keep moving, but you stay in the same place. And hedonic means in terms of your satisfaction. Suppose you're on a satisfaction treadmill. That means that whatever happens to people, they always return to their baseline subjective well-being. So you thought it was going to be bad to have a colostomy. Once you have it, you don't think it's so bad. So maybe, who cares? Well, the problem is, if that happens, then health interventions that improve the quality of life would be significantly devalued. Is that what is best for society? We might even, in the limit, argue that we shouldn't bother to treat any condition if people can simply get used to all conditions, right? If you actually take what I've said to you so far and you're like doing a lot of nodding and saying, yeah, that makes sense. We should listen to patients who've adapted, patients who've had the colostomy. They're the ones we should take into consideration when we measure the utilities, because your past self is not a good proxy for your future self. If you buy that argument, as I was kind of leading you to buy, now you should say, well, wait a minute, why do we even treat people at all? If they're going to get used to stuff, just let them suffer and they'll get used to it. You see, it's tricky. It's not obvious what we should do. And these cases of substituted judgment, which we've been considering, typically emerge in states worse than death, so-called states worse than death, which we saw earlier when we talked about patients' utilities. So people in a coma or in a persistent vegetative state or in locked-in syndrome or locked-in syndrome is an awful thing where you're conscious and can hear and see what's happening, but you can't speak or move a muscle. You can't even blink. You have no way of communicating to the outside world. Or quadriplegia, or intractive pain, or dementia, or severe schizophrenia, or other kinds of awful states. So, to finish up, the way the healthcare system treats its vulnerable terminally ill patients is instrumental to whether a patient ultimately has a dignified death. And this is related to the classic argument advanced by psychologist B.F. Skinner in a very important book called Beyond Freedom and Dignity, that dignity is not an inherent attribute of individuals originating within them, but rather is a product of their physical and social environment, at least in Skinner's view. And there's a huge debate in philosophy about this. For example, Viktor Frankl, in a classic book called Man's Search for Meaning, which he wrote after being released from a concentration camp, and which you should all read, Man's Search for Meaning, Frankl has the complete opposite view. Frankl says, I can have dignity in a concentration camp because the dignity comes from within me. It's not outside. This is structure versus agency yet again. So the argument, however, that Skinner is making is that the causes of dignity are external to the individual. Indignity originates in the treatment of one person by others. And conversely, and just as assuredly, dignity can depend upon the treatment of one person by others. And while this may be a general observation, it is especially relevant in end-of-life care. If we are serious about dignity, we should revise the way we care about the dying, not only for the sake of patients, but also for the sake of doctors. For it is undignified for the doctor and for our society to provide undignified care. Thank you. See you next time.